Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm talking to Dr Vish Ratnasuriya, a GP partner and the elected chair of Our Health Partnership, one of the UK's largest super partnerships. Vish was also recently appointed as a member of the newly formed National Commission for the Regulation of AI in Healthcare. In this episode, Vish explains how Our Health Partnership's decentralized super partnership model helps support practices while retaining local autonomy. We discuss the advantages of working at scale and the shift towards neighbourhood working, and Vish shares his views on why general practice needs to lead on this work and the opportunities for moving more care out of hospitals and into the community. We also discuss the huge role technology and AI will play in the future of the NHS. Vish explains what the new National Commission aims to achieve and the vital importance of establishing clear rules on liability and safety for new technologies. Managing a practice right now is a balancing act. That's why a team subscription to GP Online is a smart investment. Not only do you get access to GP Online, your team can access MIMS for their prescribing information, MIMS learning to manage their CPD, and GP Business for practice management advice. That means expert advice on red flags, news updates, HR, finance and contracts to keep your practice running smoothly. Support your staff and protect your business. Check out our team subscriptions at GPonline.com. I'm delighted to be joined on the podcast now by Dr Vish Ratnasuriya. Vish is a GP partner and the elected chair of Our Health Partnership, one of the UK's largest super partnerships, and also an honorary associate professor at the University of Birmingham's Health Services Management Centre. He has an interest in technology and healthcare and co-founded the Primary Care Health Tech Accelerator in partnership with the West Midlands Health Tech Innovation Accelerator, and he was recently appointed to the National Commission for the Regulation of AI in Healthcare. Thank you so much for coming on the podcast today, Vish.
Thanks very much for inviting me.
Obviously, there's loads of things we can talk about. That introduction basically shows that you've got loads of interests there. But let's start with Our Health Partnership. So Our Health Partnership is one of a number of super partnerships in England. It's what you describe as a decentralised super partnership. Can you explain what that means and how the organisation is set up?
Our founding intent was to build on the autonomy and local leadership that kind of defined successful general practice. So back in 2015, we wanted to create an organisation that had the conditions built into that so we could leverage that kind of self-improving autonomous team that's often seen as the holy grail of healthcare and build an infrastructure that supports and strengthens that. So our design principle is one of subsidiarity. That's promoting the most local decision making rather than a command and control structure. So you allow the local teams, the partners, the practices, the staff to do their best for the local populations that they interact with. And so over time, we built this learning system which looks at every aspect of care within our practices and PCNs to improve quality, safety and outcomes. And we were featured recently in the National Patient Safety Strategy for Primary Care for our learning culture and insight. And we've also built a system of resilience because things don't always go perfectly. So as well as our core offer to support practices, we've got a collective set of functions, we've got a call-on set of functions and a crisis set of functions should they be needed. And more recently, we've been involved in external rescue, which plays quite well into the policy ambitions around multi-labelled providers. And so our practices now are seen as positive outliers for access and variation, which I know is important to the Secretary of State for Health. We're having some visits for ministerially for patient satisfaction. I think our model, decentralised and perhaps not necessarily always the quickest to operate, actually gets the best for patients and populations and is most intuitive for staff and partners and practices.
So you're the elected chair. What does that role involve?
So as a governance function, so I chair a board, I chair a meeting, and I'm kind of the lead across the partnership for 110 or so partners. There's a role internally and externally as a figurehead, I suppose. And then there's quite an important role around strategy and policy. I think that's probably the most important to me because, we've created a platform, a fairly unique model, and actually what can we do with it? What's the capability of this organisation? And for me, that's where you can best enact your values, show the kind of leadership that I believe is really important for scale general practice, all whilst keeping grounded in the front lines.
Over the years, how has the partnership changed? It's obviously got bigger. Is it still growing?
So growth, I think you could look at in terms of numbers. And so the numbers are growing. I think with our practices and PCNs, we now serve about 470,000 patients. Growth can be the consolidation of what you do. So in other words, we offer more and more to our practices over the years. And growth can be the addition of extra functions. So we've moved into the research and technology space over time. And for us, that's also what we consider to be growth.
What do you see as the advantages of being part of a super partnership structure like this?
So I think the advantages of a super partnership are the supportive infrastructure, the fact that you've got experts are wrapped around you and that you don't have to deal with everything alone and in isolation as the world gets more complicated. There's the design principle of the organization where we look to promote quality, safety, and outcomes. But perhaps the most interesting thing is that with the generational change that's happening, people don't necessarily want to be part of a small team or even a single organization, but they want that networked experience. They want to have the ability to be part of a wider movement, the ability to maybe have a portfolio career and perhaps step up and step down as life changes around them. So actually, I think, for me, one of the advantages is it allows us as a large GP provider to show how the GP partnership model can evolve.
How many practices do you have and how many partners do you have?
So the partnership has about 110 partners, 30 plus practices, and some of that is consolidation of GMS contracts as time's gone on. And then we have a wider PCN footprint as well.
Because you've got this bigger organisation structure, do you have the option for GPs to take on special interests in areas and follow up things that they're particularly interested in? Is that one of the advantages?
Yes, we've got those that are really interested in technology, maybe in helping practices develop and transform, maybe within the PCN leadership space, maybe within the more regulatory kind of quality, and then maybe in the provision at scale, providing services that are traditionally done in hospitals or community trusts and things like that. So it provides the ability to give that breadth of career offering, but perhaps most importantly, within the profession, within the career structure, rather than outside it.
We're about to move into this new era of neighbourhood working, and there are lots of changes envisaged under the 10-year plan. There is a lot of concern among GPs about this move towards neighbourhood working, particularly these new contracts for neighbourhood providers and what they mean for the future of the GP partnership model. I mean, what's your view on that? Are you concerned about the independent contractor status of general practice, or do you feel that your model is quite resilient in the face of all these changes?
First of all, I truly believe in the independent contractor model. What that does is brings that kind of agency, that drive to actually be accountable and own the care for the population. That autonomy actually brings a lot of joy when it works well to your working life. I think it also, from a taxpayer perspective, really brings value because we actually do what the policymakers call overwork. We actually go above and beyond for our populations. Now, it's getting harder and harder, I think, to be an individual kind of practice within that. So I think there is something there for scale organisations like OHP to show how that independent contractor model can be taken, evolved, and maybe kind of renewed as we look to the future. And the second part of your question, I think, was around the different contracting models. So I think that we're going to see a winter and a spring of politics playing out around contracting models. I think we've got contract reform for GMS, and already we're seeing kind of a little bit of turbulence around that. I think it would be really tricky for the profession if the BMA wasn't the kind of the single point of contract negotiation, but we're seeing already that, there are moves to diversify that. I think in the 10-year plan, we saw this move to plurality of contracting. And again, there are risks for the GMS contract in that. I see a future where probably some of which we've provided in monopoly, so things like vaccine CVD, may actually be open up to kind of other organisations to compete with us under the banner of patient access and equity. And that's a really hard argument to kind of counter. So then it's left to the other layers of contracting to kind of mitigate that or give us opportunities. So what do I think about the single neighbourhood contract? I think maybe there's not many people that will be able to take that up. It's more for the single practice around the PCN. I think it might be pivoted to a system construct around neighbourhood teams. And I think the most interesting space and where I think general practice can really show its strength and depth and perhaps its renewed purpose for the future is a multi-neighbourhood contract.
There's a lot of concern as well about hospitals potentially taking charge of all of this and leading the development of neighbourhoods. As a super partnership, do you think that that helps you have more influence in local health systems and maybe more clout in the areas where you're operating about how neighbourhoods develop?
Yes, we do. We've chosen to be predominantly place-based, which means that we have a large footprint within a local geography, which will become where the multi-neighbourhood provider or the integrated health organisation or the unit where care is moved out of hospital is. So both from a national perspective and a local perspective, we're really influencing how that looks.
You're in Birmingham and the West Midlands and Shropshire. So how does that work in terms of the places that you're working in with when it comes to neighbourhoods?
So OHP spans a number of places. So within Birmingham, there's several places or several kind of populations of 250,000 where care will be moved out of hospital. And similarly, we're working in Shropshire with approximately about 100,000 patients there. And what that does is gives us an opportunity to share resource and learning across different places and actually get the best for that local population. One of the things that OHP is really good at is building partnerships. So partnerships across the local unit of geography to make sense of that whole population. And so whilst we may not make up the entirety of a place, we are a very key constituent of a place, and that allows us to help drive the development of the future of care within the values that we think are important. If I look at what a multi-neighbourhood provider will be, it will be 24/7 general practice. No one organisation can typically do that alone. So actually there is a look to build a collaborative partnership around geography, and I think we're well placed to do that.
What are you actually doing around neighbourhoods at the minute in your areas?
So I see the development of care out of hospital in two layers, the neighbourhood and the multi-neighbourhood, both having rapid developments nationally and locally. And OHP has felt it's really important to influence both. So if I can start with the national level, a number of us could have predominantly place-based GP providers are influencing what neighbourhoods look like and multi-neighbours look like through the neighbourhood task force and through the ICB and Chief Execs Forum, and to bring that kind of grounding in the front lines to both of those forums. What we're able to do then is take those kind of policy developments and bring them back home and ensure that our local populations get the best of that, because a lot of systems developed a best guess of how to develop neighbourhoods and multi-neighbourhood out of hospital care. And so not every area is the same. Lots of developments have happened, and I think it's really important to take the best of that and then a scale provider provide the elements that are missing. So at a single neighbourhood level, it's typically an integrated neighbourhood team, typically looking at frailty, inflow and outflow from hospital. And at a multi-neighbourhood level, it's that 24/7 general practice. It's the planned care, bringing care out of hospital. You know, if you do it well, you do it in the culture of general practice, holistic, multi-morbidity, rapid real time, and in that life course approach.
Some of your practices, you're in different integrated care boards. I mean, have you noticed any difference in approach in how they're coming at developing neighbourhoods, or is it fairly similar?
There's always been different approaches. If you look across the ICBs nationally, right from the very inception when we started with STPs, the RCGP had a really good program of ambassadors. I was part of that, and that was about sharing intelligence. And I think that's been a really important part of having that broader perspective nationally, because these things do tend to evolve locally, sometimes, you know, in a very kind of nuanced way that's best for local populations. So Shropshire, for instance, PCNs can have hills, rivers that divide a population, whereas in a city setting, you know, you've got, you know, very different communities of interest with very different kind of population health needs. And so, rightly so, there are differences, but sometimes it's not necessarily what's best. And actually, you look across the picture nationally and you can see that there are better ways of doing things. So what OHP, I think, allows us to do is just take that wider perspective and bring it back home to inform local conversations.
One of the things you've already touched on is about providing services in the community that maybe would have been provided in hospitals before. So as a large organisation, do you feel quite well equipped to deal with this left shift of services that the government's envisaging? And what do you think needs to happen to make that a reality?
What I'd like to see is left shift happen in the culture of general practice. Mentioned that kind of multi-morbidity approach, that holistic life course approach. Your last podcast was around continuity of care. And, I think those things are incredibly important if we're going to do the left shift well. And I think the country loses out if it looks to just recreate that episode of care approach that's just kind of lifted and dropped secondary care. So I think the design principle around what we do well in general practice is important. What I'd love to do, and I think what the policymakers would love, is if that was led by general practice everywhere. But I'm also aware that general practice everywhere is not capable of necessarily doing that. And also there are some very ambitious trusts around that want to lead that locally. So it's left to kind of local conversations.
There's a lot of question marks over what's going to happen with the GP contract going forward. You obviously just said that you'd really like to see neighbourhoods develop with general practice very much at the forefront. What were you hoping to see would happen to the GP contract in the shorter and longer term to help enable that to happen?
I think if I look at all the layers of contracting, I'd like to see kind of accountability to patients, to populations as a thread running through it. My fear is that the politics will get in the way and we won't be able to show as a sector that we can really step up and lead that. As large providers, I think there's a really important time where we need to show that we are ready, willing and capable of doing that whilst the politics plays out around us. Accountability to your population sometimes means saying that maybe you're not the best organisation to lead that individual aspect of care, but you have to work with other organisations to deliver care around a population in a collaborative nature. What I'd love to see is general practice holding the tiller, leading the contract and convening that partnership of organisations working collaboratively around it.
Do you think that the super partnership model like yours, do you think that could kind of become a default survival mechanism for general practice in this new NHS, or is there still a future for small independent practices?
I always think, back to what does the local population need? What is the provision like locally? What are the needs? So we're certainly an option. I think we are an evolved option of partnership general practice. Are we the only option? No. I think there's some very successful federations out there. And I think it's for local practices and local areas to choose what model works best for them. But what I think we do really well is have every aspect of care within the organisation. And from a business intelligence and care planning perspective, that allows us to really motor ahead in terms of really kind of thinking about how to evolve services in a way that matters for patient population and practices.
And so obviously the other thing that's a big part of the 10-year plan is technology. There seems to be an awful lot riding on new technology, new innovations that are apparently going to unleash loads of productivity and solve loads of problems. And obviously that's another one of your big interest areas is tech and how that can help general practice and patients. I mentioned at the start that you co-founded the Primary Care Health Tech Accelerator in partnership with the West Midlands Health Tech Innovation Accelerator. So can you explain a bit about that and what you've been doing as part of that initiative?
So I think what we wanted to do is take OHP on the next step of its journey to use our platform for good. Technology, whether we like it or not, is going to be part of our lives. And whilst not particularly being carried away with the zeitgeist, but more really kind of wanting to influence and shape technology's development with the values that I thought and we thought were important, we created the Primary Care Accelerator. Now, this is a partnership approach to technology development. So using our large patient population, our diversity in general practice across the kind of urban, suburban and rural settings, and using that kind of driven, a kind of agency-based general practice to work with partners from the commercial sector, from the VC sector, from the technology and startup sector to shape technology to help answer the problems that our patients and practices face, but also help technology to rapidly spread and develop and hopefully be a model for the future of the country. So what we've done is kind of tried to knit things together and therefore bring technology closer to the front lines.
Is there any specific projects you've been working on, any particular tech that you've sort of started using that you think this is absolutely amazing, this is going to change everything?
I think probably a number of different technologies that, if you use them together, really transform care. We always focus on AI. So to start with, because that's the very obvious thing to look at. But I think before I talk about the kind of three different shifts in the way we structure the companies we're working with, I just want to look beyond that to say, in the next 10 years, AI, genomics, wearables, maybe even things like quantum may actually really revolutionize the way we deliver care. But right now, AI is the thing that many are focusing on. So hospital to community, we're working with companies that are in the AI and genomics space. So an AI example is the left shift of ADHD and autism assessments, improving quality, reducing time to diagnosis. So reducing waiting lists and waiting times for patients and populations, and really kind of bringing forward care and bringing a left shift pathway out. There's one company we're working with there, and they're doing really well, both in trusts and also in the community space and beyond. And they're built on ambient voice, but there's so much more to the product. There's another one, which is a genomics. It's the equivalent of a fit test, but for a different condition. So we're looking at a left shift pathway for that. And there are two examples in hospital to community. In terms of the productivity space, we're looking at AI to improve quality and safety, because actually coding is really important to that. And there's an AI voice product that we're working closely with, because I think that will really revolutionize the way we think about interfacing with our patients and populations.
The ADHD thing, that's really interesting. What's that AI tech doing to help you cut waiting lists? Is it helping to support GPs to do more of these assessments?
If we start back to the patients and families, it's helping to kind of capture information from them, whether it's handwritten, typed, voice, so that whether it's directly from the education institution, if it's a young person. And that means by the time we get to a GP, there's a pre-packed set of information. And that means, for the general practice perspective, we don't take a lot of time to pick up that information to translate it into the given pathway for a local area. Actually, it's captured for us, and all we need to do is assess whether actually a threshold has been met. Then the technology helps to do the referral given local pathways. For the receiving, clinicians, whether that's within the community, whether it's GPs with a special interest, or whether it's a specialist service. And I know where I think the future lies. It's more with the GPs with special interests, with MDTs around them. It means the information, again, is pre-packed. It's not, you don't duplicate effort to recapture it. Again, there's not a kind of information decay, lead time lost for the patients. You're back to capturing the information, and then a more kind of detailed diagnostic pathway can focus on the gaps in the information, on choosing to focus on the patients and family to make sure that actually, there's a meaningful interaction with them, that the diagnostic information is at the standard that's required, and therefore a diagnosis can be reached. And so I think it's a really interesting product, because it looks at left shifting all of that information capture and streamlining the pathway.
Yeah, that's really interesting. The other thing I mentioned at the start is that you've been recently appointed to the National Commission for the Regulation of AI in Healthcare. What exactly is that commission going to be doing?
So it's a bit of a mouthful, isn't it?
Yeah.
And really, I think what the commission is trying to do is bring together sector experts, from clinicians to providers, regulators, policymakers in Whitehall, legal and ethical professions, to help do two things. One is bring medical device regulation from a time where actually it was physical devices, and it's kind of been repurposed to AI. We want to bring that forward to a living, breathing framework that can really adapt to that rapidly evolving landscape that AI is, rather than be something that's forever trying to catch up. So that's number one. Number two is something I really believe in, which is that kind of wider public discourse and debate about how do we want this technology to work? What do we want it to use for? What is the framework in which society wants AI to be used in within healthcare, so that we can then have a really clear set of rules the public trust in, that clinicians and providers are aware of, and that developers now know are the rules of the game, so that the MRHA can kind of oversee to then help technology rapidly develop, help us answer the problems we face, but also then rapidly develop in a way that we want as a society.
Part of your role on that commission is to represent the GP perspective, and there's a lot of varying views about AI within the profession. Lots of people really up for it, think it's going to be amazing, and others are really cautious. So what are some of the key concerns you're going to be raising as part of this work?
So I think some of the key things that I'll be raising are actually, first and foremost, this needs to work in the real world. There is no point having a set of regulations that don't actually help us day to day on the front lines in our practices. So that's number one. Number two is I think it's really important that as patients, as professions, as practices, as providers, that we need to have a set of rules that help build the safety and trust in these products, especially as they rapidly develop and evolve. I think there needs to be clarity around liabilities, and that's something as a clinician I think about a lot. I really want to push the Commission to, and I think they're doing this well so far, to really bring that wide-reaching public debate to inform what our recommendations are, so that we end up with a set of rules that are really clear all round and really help us both on the front lines and help us receive the technology that's developing, because it really fits with what we are addressing and trying to solve on the front lines.
It sounds like a really important bit of work that needs to be done. One of the biggest areas where general practice is likely to see quite a big change, well, it already is now, but in the coming years as well, as around ambient voice technology and ambient scribes. Lots of practices already using this tech, and obviously the NHS is keen to roll it out to more practices. It's a big mention in the medium-term planning framework. But there are still quite a lot of concerns about its use, aren't there, in terms of how accurate it is, what regulation needs to be in place. What are your views on this technology generally, and what needs to happen to make sure we can roll it out safely?
So I think ambient voice is a very base case use of AI, whilst the MRHA is actually going to come out quite quickly on a really clear set of rules to guide the development of ambient voice. I think if we only saw AI as that, I think we would be remiss, because actually, fast forward a couple of years and actually kind of slightly autonomous agentic AI will probably be most of what we see. We need a clear set of rules that are reshaped to allow patients to have that right of recall, to have the ability to see the whole transcript, not just a summary. I think for clinicians, we need to have also the ability to know where liability sits. Is it with us? Is it with the technology? I would love clinicians to have, either from an organizational perspective or an individual perspective, a really clear view on how to interface with a given set of trusted ambient voice tools, so that we kind of reduce the unknown unknowns when we interface with new technology, and actually can just get on with the work in front of us and use the technology if we see that we do want to use it. I do know some people are using this a lot. I know others have started to try it and then moved away from it, especially in the quick transactional consultations, and maybe use it for more of the complex, comorbid consultations. And perhaps that's where I see the most value for it in the future, where perhaps we're in a consultation where there's a lot of safeguarding, there's a lot of complexity, and actually we use ambient voice to then enable us to really focus on the person in front of us.
The 10-year plan, I mentioned that earlier, has got very ambitious goals around the use of tech and AI, the whole analogue to digital shift. How do you see things changing over the next 5 years, for example, when it comes to this? Aside from those AI scribes, what else, other key developments do you think GPs are going to see happening in the next couple of years?
I think the first thing to say is I don't see the 10-year plan in isolation. So I think I was fortunate to be involved in the development of that, as well as the life sciences sector plan. So I think you need to take a step back and look at both of those together. I see the 5 big bets: AI, genomics, wearables, data. I would say for general practice, I'd probably not see robotics so much. I would see more contracting models as one of the things that I would see as the 5 kind of big bets that we have. So where do I think that takes us? Well, I don't see the 3 shifts happening in isolation. You have to have a tech-enabled left shift that focuses both on the individual and the population. I see a real challenge to the leadership styles we have, the way we think about things, because technology is rapid innovation. It's failing quickly, failing fast, whereas NHS is all about safety first, kind of quite bureaucracy heavy contracting models. And so if we get that right, actually a really interesting set of care pathways that really work for patients who are open to them, that we have very analog pathways for patients that want that. I see care pathways that work for the younger generations of professions that really want to be in that ecosystem of care. And I also think there'll be roles for those of us maybe that don't want to be so. But I think we're at a time where we need to see how this plays out from a political perspective, from a kind of clash of cultures perspective as well.
And how realistic do you think the overall ambitions in the 10-year plan are? Do you think that they can actually all be achieved?
I think they can. I think it's kind of beholden on us as leaders to kind of create the conditions where they're most likely to succeed. I think, we always tend to be a little bit kind of reactive, tactical, to focus on the here and now, the year to year kind of contracts and what they mean. But actually, if we raise our eyes to look forward to the horizons, I think this is a really interesting time to be working as a GP, to be within the leadership community. I think we need to engage with it. The politics, austerity, the lack of funding to do this will always try and take us away from it. But I think we need to start probably with a few simple things, show that it can work, and build on a minimum viable kind of tech-enabled future rather than try and do all things for everyone at once.
Honestly, Vish, that has been so interesting. It's been really fascinating talking to you. Thank you so much for coming on the podcast.
Thanks very much for having me, and if you've got this far, for tolerating my voice, because it's not in the best shape.
Well, that's it for this week. Thanks so much for listening, and thanks again to Vish. This is our last episode of 2025, so I'd like to say a big thank you to you all for listening over the past year, and thank you for all your support. We'll be back in 2026 when we'll be speaking to more key people from the world of primary care, as well as giving you our own take on the key news stories affecting general practice. In the meantime, Merry Christmas and Happy New Year from all of us here at GP Online.